Peripheral neuropathy refers to damage or disease affecting the peripheral nerves, which are the nerves outside the brain and spinal cord. This condition impacts about 1% of adults globally, with symptoms ranging from mild numbness in the toes to severe disability requiring a wheelchair. The nerves affected can be sensory, motor, or autonomic, leading to a wide variety of symptoms. Understanding what peripheral neuropathy is lays the foundation for recognizing its impact on daily life and the importance of early identification and management. Peripheral neuropathy is more common than many realize, especially as people age. While it affects about 1% of all adults, the prevalence rises to 6–10% among those over 60. Diabetes is the leading cause, impacting over 206 million people worldwide. The burden of this condition is significant, often leading to chronic pain, mobility issues, and reduced quality of life. Recognizing its widespread impact helps us appreciate the importance of prevention and effective management strategies. Symptoms of peripheral neuropathy can vary widely. Most commonly, people experience numbness, tingling, or burning sensations in their toes and feet, which may gradually progress up the legs and even to the hands. Pain can feel stabbing, electrical, or like shocks. Some may notice muscle weakness, difficulty walking, or changes in reflexes. Autonomic symptoms such as dizziness when standing, dry mouth, or digestive issues can also occur. These symptoms often develop slowly over months or years, making early recognition challenging. Peripheral neuropathy is not a single disease but a group of disorders. The most common type is length-dependent peripheral neuropathy, also called distal symmetric polyneuropathy. This form typically starts in the toes and feet, progressing upward. Other types include hereditary neuropathies such as Charcot-Marie tooth disease and neuropathies caused by toxins, medications, or vitamin deficiencies. Understanding the different types helps guide diagnosis and treatment. Diabetes is the most common cause of peripheral neuropathy, accounting for up to 50% of cases worldwide. Diabetic neuropathy often presents with pain, tingling, or numbness in the feet, sometimes accompanied by mild weakness or autonomic symptoms like dizziness or digestive issues. The risk increases with longer duration of diabetes, poor blood sugar control, obesity, and high cholesterol. Early detection and management of diabetes are crucial to prevent or slow the progression of neuropathy. Beyond diabetes, peripheral neuropathy can result from hereditary conditions like Charcot-Marie tooth disease, exposure to toxins such as alcohol or certain medications, and nutritional deficiencies, especially vitamin B12. Some cases remain idiopathic, meaning no clear cause is found even after thorough testing. Recognizing these diverse causes is essential for accurate diagnosis and targeted treatment. Peripheral neuropathy arises when sensory, motor, or autonomic nerves are damaged. This can happen through several mechanisms: direct injury to the axon, demyelination, loss of the protective myelin sheath, or dysfunction of Schwann cells which support nerve health. Chronic high blood sugar, toxins, or immune attacks can disrupt nerve function, leading to symptoms. The longest nerves, such as those reaching the toes, are most vulnerable due to their high metabolic demand. Thorough physical exam is key to diagnosing peripheral neuropathy. Clinicians check for sensory loss by testing vibration, touch, pinprick, and temperature sensations, starting at the toes and moving upward. They also assess muscle strength, reflexes, and look for foot deformities like high arches or hammer toes. Gait and balance are evaluated, especially in severe cases where walking may be unsteady. These findings help distinguish typical neuropathy from other conditions. Not all neuropathies follow the typical pattern. Red flags include rapid onset of symptoms, severe motor weakness, prominent autonomic symptoms, asymmetry, or associated systemic signs like weight loss or fever. These atypical features may suggest immune, infectious, or neoplastic causes and warrant urgent referral to a neurologist. Early recognition of atypical presentations can lead to timely treatment and better outcomes. Laboratory tests help identify treatable causes of neuropathy. Recommended initial tests include blood glucose for diabetes, serum B12 with metabolites to check for deficiency, and serum protein electrophoresis with immunofixation for monoclonal gammopathies. Additional tests may be needed based on clinical suspicion, such as hemoglobin A1c or glucose tolerance tests. These investigations guide further management and help rule out other conditions. Electrodiagnostic studies, including nerve conduction studies (NCS) and electromyography (EMG), are valuable tools for confirming peripheral neuropathy and identifying its type. NCS can show whether sensory or motor nerves are more affected and help distinguish between axonal and demyelinating neuropathies. EMG can reveal patterns of nerve or muscle involvement. These tests are especially useful when the diagnosis is unclear or when atypical features are present. In certain cases, skin biopsy can help diagnose small fiber neuropathy by measuring nerve fiber density. Autonomic testing, such as the quantitative pseudomotor axon reflex test, assesses sweat gland function and is reserved for patients with prominent autonomic symptoms. These specialized tests provide additional information when standard evaluations are inconclusive or when small fiber or autonomic neuropathy is suspected. Medications, especially chemotherapy agents like paclitaxel, vincristine, and cisplatin, can cause peripheral neuropathy. Other drugs, including some antibiotics, antivirals, and immune modulators, may also be culprits. Symptoms often develop during or after treatment and can persist even after stopping the medication. Recognizing medication-induced neuropathy is crucial, as adjusting or discontinuing the offending drug may prevent further nerve damage. Deficiencies in vitamins such as B12, B6, and thiamine can lead to peripheral neuropathy. B12 deficiency is often seen in people with poor absorption or strict vegetarian diets, while B6 toxicity from excessive supplements can also cause nerve damage. Thiamine deficiency, known as beriberi, is rare in high-income countries but can occur with alcoholism or malnutrition. Early recognition and supplementation can prevent irreversible nerve damage. Hereditary neuropathies, such as Charcot-Marie tooth disease, are genetic disorders that affect both motor and sensory nerves. These conditions often present in childhood or adolescence with muscle weakness, foot deformities, and sometimes minimal pain. Genetic testing can identify specific subtypes, guiding prognosis and family counseling. While most hereditary neuropathies lack specific treatments, supportive care and physical therapy can improve function and quality of life. Monoclonal gammopathies, such as multiple myeloma or Waldenstrom macroglobulinemia, can be associated with peripheral neuropathy. These conditions are more common in older adults and may present with atypical neuropathy features. Diagnosis involves specialized blood tests, and treatment focuses on managing the underlying plasma cell disorder. Early referral to hematology is important for optimal care. Neuropathies are caused by autoimmune or inflammatory conditions, such as chronic inflammatory demyelinating polyneuropathy (CIDP) or vasculitis. These forms often progress rapidly and may respond to immunosuppressive treatments like steroids or intravenous immunoglobulin. Prompt recognition and referral to a neuromuscular specialist can halt progression and improve outcomes. Loss of sensation can lead to injuries, ulcers, and infections, especially in people with diabetes. Daily foot inspections, proper footwear, and checking water temperature before bathing are essential preventive measures. Podiatric care is recommended for those at high risk of foot ulcers. Education and self-care play a vital role in reducing complications from sensory loss. Neuropathic pain can be challenging to manage. First-line medications include gabapentin, pregabalin, duloxetine, and amitriptyline. Topical treatments like lidocaine or capsaicin patches may help some patients. Combining medications from different classes can provide added benefit. Opioids are generally not recommended. For persistent pain, referral to a multidisciplinary pain clinic or consideration of neuromodulation techniques, such as spinal cord stimulation, may be appropriate. Weakness and balance problems from neuropathy can increase the risk of falls. Physical therapy focused on gait and safety is helpful for mild weakness, while occupational therapy assists with hand function. Severe cases may require orthoses, walkers, or wheelchairs. Autonomic symptoms such as dizziness or digestive issues may need additional testing and management. A comprehensive approach improves independence and quality of life. Outlook for peripheral neuropathy depends on its cause. While some forms, like those due to vitamin deficiency or immune conditions, may improve with treatment, complete reversal is rare. For many, symptoms persist despite optimal management. Early diagnosis, addressing underlying causes, and supportive care are key to improving quality of life. Ongoing research continues to seek better treatments and prevention strategies for this complex condition.